it gives a lot of hope when you hear alternatives to joint replacement. And frankly, if there's a way I can avoid a joint replacement or a surgical procedure, I'd like to hear about it. As your joints begin to fail, there's a set course of options that become available. These are like windows that open and close as your joints go through various stages of the development of arthritis. So this is one way of looking at the problem and the landscape now for taking care of joints. I take care of children, young adults, adults, middle age, and the elderly. And the problems and the solutions change. In the younger people, we have a very good chance of being able to help them with arthroscopy, minimally invasive procedures. In the elderly, we pretty much have joint replacements, which actually have a very high success rate. The area where the most research, the most opportunity to help people actually is in this middle age group. This is where they're not, the window for joint replacement isn't there yet. The window for arthroscopy has passed, and we need to do something because the joint is partially gone because of arthritis or trauma. And this is another way of looking at it. If your joint still is allowing you to play tennis, you may actually have the opportunity or the window for a less invasive procedure despite being of a similar age. 43 million people have arthritis, and by 2020, 60 million people affected by arthritis. Here, 21 million Americans suffer from arthritis. And this is osteoarthritis. Osteoarthritis is a type of arthritis. It's by far the most common type of arthritis, and it's what you would call wear and tear arthritis, which most people have when they come in. Other types are inflammatory arthritis, like rheumatoid arthritis, arthritis secondary to diseases like gout and crystal diseases, or post-traumatic arthritis as a result of injury and accidents. And osteoarthritis has different presentations in different people. Some people can't understand why it comes on quickly, and other people, and the majority of people, will be brewing arthritis and have painful joints that's been coming on for years. The most common symptoms from arthritis: pain and stiffness, swelling, and then it eventually will cause difficulty in doing the things you like to do in your life. The rheumatoid arthritis can be a particularly crippling type of arthritis because this one, the joints actually are being attacked by your body. It's usually coming on in middle age, so it can come on in the elderly. One of the things that you may see that is a tip-off for someone with rheumatoid arthritis would be someone's hands, that the fingers look, all of them look like they go to the side. That's a very typical finding for people with rheumatoid arthritis. So we're talking about degeneration of joints. Early, middle, late. It's a continuum. It can affect more than one joint. The most common joints: base of your thumb, knees, shoulders, and it can affect most of the joints you use more commonly. And a lot of people will have, after they've done something and they're strained, they get up the next morning, they feel it. Now these people feel this every day. And of course the problem is that arthritis affects your mobility, activity, and therefore your independence, the ability to do things on your own. What we're talking about in all arthritis is the coating of cartilage that is adherent to your bone. If you've opened a chicken bone and looked at that glassy surface, inside a joint, that's the tissue that we do everything to try to save. Because unfortunately, as opposed to muscle or skin, you get one coating. Unless you're very, very, very young, you lose the ability to regenerate or heal that cartilage. If you're young and you're playing sports and you hurt your knee, you start getting little surface injuries, little dings. And over time, things add up, and then it gets worse. And then there's a problem where that cartilage, for some reason in our genetic code, stops being able to actually nourish itself, and it begins to thin in thickness. And then it loses the ability to bear weight. It's kind of a spongy material. So it's built, when you load it, to hold weight. It has a hydraulic principle. When that begins to thin, you lose the ability, and the weight and stress goes through to your bones. And then your bones feel that stress, and they respond. And they only respond by making more bone. They make spurs. They get flatter. And these are the things that I start seeing on your x-rays when you come in, that tell me, oh, you're developing arthritis. For instance, in a knee. Here's a normal knee. We have the bones. We have three surfaces that we talk about in a knee: the thigh bone, the leg bone, and the kneecap. And you can get deterioration of all three, two of the three, or only one of the three. Here's what arthritis is: the loss of that cartilage coating of the surfaces of your joint. This is a illustration of wearing in a particular area of the joint. It may not be all the surfaces. And in the early stages, it looks more like this. The joint still has its normal shape, but it's like, think cavities in a tooth in your knee, just some areas that are worn. This is what I look at after I examine your knees. I look at your x-rays. The x-ray on the right shows there's no space between the bones. On the left, these are pictures with you bearing weight and actually trying to squeeze the cartilage together. When you bear the weight here, there's no cartilage. That's the problem. Now, what are we going to do for arthritis? Well, when you come and see me, I always start conservatively. And the things that we do, we use medications like anti-inflammatory medications, which can be as simple as Advil, Aleve. Some people take Tylenol. All medications have side effects. All medications have interactions. So you have to understand how to use these medications right, and they're not for everybody. So we use things like physical therapy. Bracing is used for arthritis. A lot of people will go to Dick's or Walgreens and get a support. Sometimes that helps some, even by keeping them warm. But big braces usually aren't used for osteoarthritis. I mean, if you've seen me more than 2 or 3 times with early arthritis in your knee, you have probably felt my injection, because it works. But it's meant to decrease the inflammation or to help lubricate your joints. It doesn't cure. The solution would be something that can regenerate joint cartilage. Put it back. Do I know, is it a year away? I don't think so. I mean, I think it's still a long way away. So the options are how to preserve and resurface what you have. And resurfacing means putting a new surface on. And there are 2 types. Biologic, meaning we put new cartilage in, or mechanical, which means we put artificial materials in. So arthroscopy, which is a surgical procedure with a telescope through little portholes, is a way to clean, buff, and sometimes we can trick the knee to try to make a replacement surface. This is typically used for young people with very focal cavities on the surface of their knee. The biologic resurfacings, I'm not going to spend much time on, are like taking a cadaver and taking a cartilage surface, a plug or dowel, and popping that into your knee. It's again done for younger people, typically under 40, a very focal area of damage where the rest of the knee is okay. The alternative to a biologic is a mechanical partial resurfacing, which is what I'm fairly excited about. In simple terms, think more, again, like a dentist putting in a filling or a partial cap, or these are smaller procedures that address localized area of damage. There's a point in which the damage gets so far, or the progression will be such that just a partial isn't appropriate. So the final solution for arthritis in the major joints, knee, hip, shoulder, is what's called a total joint replacement, or a mechanical resurfacing of the entire joint itself. Partial joint replacement, which is what I showed in that first slide. This is a procedure where the damaged or diseased surfaces of the joint are replaced, leaving the majority of your joint intact. It's less surgery, significantly less surgery on the inside of your joint. So of course you think that it may be less painful and your recovery may be shorter than with a total knee replacement. I think the most important part of this is that we're leaving most of your joint intact. Because with a total joint replacement, especially in the knee, many structures, as far as ligaments, shock absorbers, are removed. And for these partial joint replacements, probably they're a quarter to a third, maybe, it can be, and in the future maybe even less of your joint, and only the surface where those potholes are touched. All the rest is left. Here you have a focal area on the thigh bone. Not the whole knee. There aren't ligament injuries. There aren't spurs. It's not bone on bone everywhere. And this is the type of knee that I consider for partial joint replacement. It's enough to cause you problems, dysfunction, daily pain. And this is the type of knee that I think is appropriate for this type of partial replacement. So this is a shoulder with a partial mechanical resurfacing. When we say unicompartment, that refers to what I was talking about with the knee, where there's an inner compartment, an outer compartment, a kneecap compartment. So this is a partial resurfacing in one compartment. It fills the pothole. It gives a smooth surface so when a person moves, walks, they don't fall into the pothole and the stress isn't transmitted to the bone. That means it doesn't hurt anymore. You see on top there's a screw. Again, this sort of looks like a dental. There's a post that's implanted in your bone, and then they really cleverly made a hole in which there's a little stem on the back of this metal piece that it's not quite a snap, but it fits in so tight that it won't come out. This is one of the things we're talking about. This is a very graphic slide. Look at the difference
between the total knee replacement on the left and a arthrosurface resurfacing on the right. There's a lot of difference on how much bone has been removed. The total knee on the left, the tibia, looks like there's a lot of screws and big posts. Look at the difference. This has, the Arthrosurface has one smaller screw, and it's just replacing a smaller part. And this one on the right actually has resurfaced both the thigh bone and the leg bone side. It's pretty graphic. I mean, so this is why I'm so excited, because I can see, boy, that's a lot less I can do for my patients. And if that solves the problem, who wouldn't want that? Where around the body are we using these smaller resurfacing? Trochlea is part of the knee. The femur, again, is part of the knee. The kneecap, patella is part of the knee. First MTP, it's your big toe, like where you get bunions.
Oh my gosh.
They can resurface that joint. Shoulders, they're doing it. So once again, the limited resurfacing advantages. You don't take as much normal tissue. You're leaving most of the anatomy. Again, this is another nice point, this don't burn your bridges. Which means, if something happens or the rest of your knee deteriorates, it's an easy conversion from this to something more substantial, like a knee replacement, which is, to me, is also a great thing, that you don't put yourself in a bind, and there's an easy way to take care of a problem. And so, yes, like a dentist fills a cavity. I mean, if you think in terms of dentistry, sometimes it becomes easy. Total knee is like a full cap over your tooth. Partial resurfacing to me is more like a cavity. You still have the tooth. They have done gait studies. No total knee actually walks in a normal fashion. A partial resurfacing like this will, because your ligaments are left. The rest of the shape of the surface of your knee is left. Again, these are great advantages. Relative indications. Middle age. They're still so active. The concern is, if I have a joint replacement, it won't last. I'll wear it out and then what? Focal lesions, that means a cartilage defect or a pothole. Osteochondral just means a pothole with some bone underneath. So both the cartilage and the bone affected. AVN is that condition of avascular necrosis that we mentioned before. This is a very nice solution if it's focal and the rest of the knee is okay. OCD is very similar to this avascular necrosis, but actually it can occur in your teen years. Localized lesions. This gets into what the other side of the knee, how much arthritis can be on the other side. Failed, of course you should have failed conservative treatment before anyone starts operating on you. And it's an alternative to the other procedures, like a hemiarthroplasty, or a full unicompartmental knee joint replacement, or a full joint replacement. And again, stable ligaments. The rest of the knee is okay. So these are a couple cases that you can look at of arthrosurface replacements. Again, here's a 54-year-old, likes to play tennis, problem just on the inner side of the knee, and they put in this partial mechanical resurfacing device called the Arthrosurface. This is the one with the most hardware. This is an athlete who tore a ligament playing football, almost certainly. The two little screws are securing a ligament reconstruction they had. Then they go on and develop post-traumatic arthritis. And in this case, the post-traumatic arthritis was under the kneecap and on the inner side of the knee. So what they do, they put just two little partial resurfacings. This one is under the kneecap. This one is on the inner side of the knee. Hopefully, this type of procedure allows somebody to have 15 good years of being very active.